Any departure from that and the expected value of what the doctors and such will want will be higher. So if we follow this process, this protocol, we can minimize the risk. This says absolutely nothing about where the money is to come from. That's a second question, and it's a very important one. Investors, ordinary patients, etc., can sign contracts to pay a fixed fee monthly in exchange for a finite amount of care at variable cost only. Care that is paid for and not needed can be given to charity or to the uninsured and the uninsured poor. The right to purchase such care can be designed by insurance companies, cooperatives, or pretty much anyone. This analysis allows shrewd patients to buy health care scripts and maybe even make a profit from them. There is no reason not to allow such speculation. If you take note of airplane overbooking, in which passengers can take payoffs in exchange for surrendering their reserved seats, that's an example of damages paid to a customer. Now let's take a look at insurance and technological improvements and the decision of do you live or do you die. The life-death decision is very important. It should not be assigned to the government with its death squads. Only the patient can make that decision. And if the patient cannot make that decision, then the patient should ask for some help from a higher power. Not the government, but God. Health insurers are trapped by changing risk. If you buy a house and you insure it, you pay a premium every month. If you buy a car and you insure it, once again, you pay a premium every month. If you buy a bigger house or a more expensive car, the risk, as assumed by the insurance companies, goes up. And so do the premiums. If medical technology improves, the amount at risk goes up, but the premiums don't. You're going to have a very unhappy medical insurance company. So what patients need to do is say, here is the level of service that I want insurance to cover. If there are any new changes in what's available, it's okay if they're not covered. I really don't want my premiums going up. I'm willing to let things alone. If heroic measures to prolong life of someone terminally ill are expensive, it's not the taxpayer's duty to pay for it. If you bought insurance, the insurance can pay for it, and if not, then you have made a conscious decision that such expense is not worth it. You make that decision when you're young and healthy, and you live with it later on. The responsibility should be individual and personal and should not be delegated to the government. This is a time when I have to tell most citizens you are selfish. You can't tell the government to look after you, and having done so, avoid making the decision. The one-size-fits-all insurance policies are just plain unreasonable. Different people have different religious beliefs, different expectations as to how vigorously they should be kept alive. Tax subsidies for the poor may be a good thing, but let's make sure that they are explicitly identified as such. It may be that certain people who cannot afford the premiums for the insurance to provide care late in life should receive some help paying the insurance premiums. That's a political decision, but it should be made out in the open, not disguised. Now let's take a quick look at pre-existing medical condition. and the problem with insurance. Unlike life and death, this is actually very easy to solve. The increase in premium that results from having a chronic condition can be translated by standard financial calculations into a lump sum. An insurance company can either take a large premium from you, or if you bribe it once with a very large amount of cash, it will be content to have a small premium. When you stop being insured from a company and you have a large premium, then the insurance company is, and you have a pre-existing condition, then the insurance company is going to be very happy to get rid of you. It should pay. It should pay the insurance company that takes over. Then insurers will not be so quick to harass chronically ill patients. They'd have to pay if the patient stops getting insurance from them. Meanwhile, the insurance companies will be perfectly happy to take on chronically ill patients because they know that they will be paid a big lump sum if they do so. Let's take a look at research can be pulled out of politics completely with one very simple rule. Pay only for results. Don't pay for the progress that is intended to lead to the result, or the researchers will simply arrange for perpetual progress and will not get anywhere. Investors can look at a non-revocable promise to pay $50 million, $100 million, or some other large amount in exchange for an answer to a medical problem. Then the investors can hire whomever they wish at their own risk, and when the result has been found, the problem has been solved, go claim the money and save money. First, pain management and opiates. Many people have chronic pain. They require such things as hydrocodone, oxycodone, morphine, fentanyl, and other very addictive drugs. The Drug Enforcement Administration does not and cannot offer rigid guidelines as to when such drugs should be prescribed, because not all pain can be traced to objective physical findings. So if the DEA says it is okay to prescribe to patients who have this and that presentation, then the drug addicts and the drug diverter street dealers will fake those symptoms and the drugs will be prescribed. So the Drug Enforcement Administration has had to provide vague guidelines and an atmosphere of intimidation so that doctors are frightened. That's a real pain. What can be done is to take various combinations of inert ingredients, and with 10 different inert ingredients that can be added in low or high concentrations to a hydrocodone pill, for example, it is possible to code the pills so that they can be traced to one patient, just in case a patient turns out to be a drug diverter. They can be traced, and whoever diverts the pills can be arrested. Maybe this is worth it, maybe not. Now let's take a look at attacking waste. Misuse of healthcare due to social failure, the inability to socialize, to interact with people, to merit having someone nearby who can listen to what you say, the ability to speak, be heard, listen, and interact in a friendly, social way. Some people don't have that or they lose it. Perhaps half of all internist visits are preventable if patients take social needs to their friends instead. People often complain to psychiatrists and psychologists about how they don't have social confidence. If they could learn the skills and get the competence, the confidence,